Welcome to Jewish Midlife. Hi, I'm Devora Krasnianski, your host. And in this episode, Dr. Avigayil Rapp and I delve into HRT, Hormone Replacement Therapy, also known as menopause hormone therapy. Many people have lots of questions, and that's what we're addressing. We respect anyone's choice to take HRT or not, and our goal with this episode is to help you make that choice from education and not from a place of fear or lack of information. So basically, in perimenopause, as our periods become more erratic and less frequent and then stop entirely, our bodies are producing less and less estrogen. This decline in estrogen levels can affect multiple systems in the body, and the severity and the type of symptoms can vary widely among individuals. Some will have hot flashes or brain fog or sleep disturbances or weight gain. There's dozens of symptoms in this stage. Some will have more than one. Some women seem to get by without any symptoms. And then beyond these immediate symptoms, studies indicate that reduced estrogen can also influence bone health, heart health, and cognitive function. So our spotlight today is on hormone replacement therapy, which is a key method of replacing that estrogen. Research emphasizes the importance of maintaining adequate estrogen levels, and HRT is one approach to achieving this, and that's what we're discussing today. HRT involves supplementing the body with hormones, typically estrogen with or without progesterone, I will talk about that, to alleviate symptoms and provide potential benefits to bone health, heart health, and cognitive function. So while HRT is a viable option, we recognize that individuals may prefer non-hormonal approaches due to personal preferences, medical history, or concerns about potential risks. So lifestyle modifications, including a healthy diet, regular exercise, and stress management can also contribute significantly to overall well-being during perimenopause and menopause. That's a whole different topic. So in this discussion, Dr. Rapp will talk about the WHI study about HRT, its findings, and she'll also shed some light on the evolving landscape of HRT since that study was stopped over 2 decades ago. We'll talk about the relationship between HRT and breast cancer and other health issues, and we'll try to offer a comprehensive understanding of various health considerations. We'll also provide guidance on engaging in an open and constructive dialogue with your healthcare provider, acknowledging the importance of personalized approaches tailored to the individual preferences and health needs. We navigate the intricacies of HRT, perimenopause, and menopause. So join us for an enriching conversation as we navigate the intricacies of HRT, perimenopause, and menopause. Our mission is to empower you with knowledge so you can make informed decisions that resonate with your unique health journey. So let's delve into this informative episode with Dr. Rapp. I'm so excited to talk to you, Dr. Avigayil Rapp, about this important topic of menopause, HRT, and what we can be doing for ourselves with menopause and in midlife in general. So there's so much to talk about. I hope that we can cover a lot. But before we even get into the topic, can you talk a little bit about what you do specifically with menopause and what you do just in general? So thank you.
Oh, thank you so much for having me. So my name's Dr. Avigayil Rapp. I am an internist who is really passionate about women's health. For the past 3.5 years or so, I was practicing primary care at Brigham and Women's Hospital in Boston. And a few years ago, I learned about menopause as a specialty, and in training internal medicine, but also in GYN and most residencies, there's really not that much training on menopause care. So I got more interested in it. I became certified through the North American Menopause Society, which is now the Menopause Society. And started to practice menopause care within my primary care practice. And I also spent time working in the Brigham Menopause and Midlife Clinic. I recently relocated to New York, and now I'm planning on focusing solely on women's health, midlife, menopause care.
So thank you, because there's not a lot of people who really understand menopause in general, and then even more specifically, that last level of like the Jewish life, that whole thing. So I'm really grateful that I found you, so we can really be talking, because you really understand the whole interplay of Jewish life and menopause, even though it's not your personal experience yet. But I think that your work experience and you can bring to it is really exciting. I really so enjoyed our pre-conversation, so I'm really excited to talk about this.
Yes, and
So this big topic, menopause, but there's this, and I really want to focus just on mostly on HRT, which is hormone replacement therapy. And there's a lot of myths and so there's a lot to debunk and a lot to explain. So let's just get straight into it. What's happening in menopause that we actually need to be talking about, the HRT part of it?
Yeah, so HRT, which is hormone replacement therapy, which is often also called menopausal hormone therapy, is something that in America has kind of gone on a pendulum. There was a while where everyone was on hormones. An 80-year-old walked into the office, no history, and they'd say, "Oh, take hormones, you'll feel better." And I was not practicing medicine at this point, but this is what I've heard from colleagues and from people who were at that point. It's kind of in the water, because there was talk about all of these benefits. And then there was this big study called the WHI, the Women's Health Initiative, which was a government funded study, and it was meant to look at heart disease and whether hormone therapy could prevent that. And it was this massive trial. There was 2 arms. There was women who were taking just estrogen. Oh, sorry.
So before we go into that, let's just talk about why people were even thinking of taking HRT. Like, what is happening in the female body at midlife?
Oh, sure. Sorry. Yeah, so in perimenopause, throughout a woman's reproductive life cycle, there's rises and falls in lots of hormones. The main 2 we talk about are estrogen and progesterone throughout the menstrual cycle. Towards the perimenopausal time period, those instead of going like this every month,
And
those
for those who are
hormones.
listening, we're talking about going up and down as a cycle. Go ahead.
Oh yeah, sorry, up and down as a cycle. They kind of go all over the place. Estrogen can get really, really high. It can get really, really low. And then post-menopause, so after women have stopped menstruating and they are no longer having those cycles, then both estrogen and progesterone are very, very low. So we kind of have these 2 separate time periods that lead to their own difficulties. So we have these large fluctuations in perimenopause and then just really low in postmenopause. And so it seems like people who have more estrogen for longer periods of time do better in lots of ways, which is why they started looking into these things to seeing if replacing those hormones could be helpful for lots of things. And then in 2002, the Women's Health Initiative, the WHI, got on TV and they said, we're shutting down because of safety reasons. It crossed our threshold for being unsafe because there was too much breast cancer was found. So everyone was kind of terrified, especially the kind of way it was done. It was on TV. You had the people come up and say, we're finished this trial. It was like a really big news story. And so everyone stopped. And now we're over 20 years past that, and we're seeing that a few things. So since that time when a lot less people are taking hormone therapy, we're having a lot of difficulties. I mean, women, and I'm not just talking about symptoms. People are having terrible symptoms that could impact their quality of life. The amount of women in midlife that lose out on jobs or quit their jobs because of menopausal symptoms that are not being dealt with is astronomical. All of those things, and we're seeing increased fractures, osteoporosis, heart disease, all of those things since kind of we abruptly stopped. So over the past bunch of years, there has been a lot of people looking into this and saying, what is going on? And the pendulum's kind of swinging back, and we're realizing that in our, I would say, fears, we're missing out on a lot of important things. And while hormone therapy is definitely not for everyone, it's for a lot more people than it's being offered to. And today, most societies, I mean, every society says that the most beneficial treatment for symptomatic menopausal symptoms are hormone therapies. There are other options for those who can't or don't want to, and those are important things to talk about too. But on top of the fact that people aren't talking about it in general, people aren't bringing up their symptoms to their doctors aren't bringing it up to them, a lot of it's because a lot of doctors aren't trained in menopause, but also a lot of doctors don't have time. Um, GYN, internal medicine, there's so many check boxes to get through at every visit, that even if you do say, are you having hot flashes or night sweats? The answer is yes, you might not have time to talk about it. And then if you tell the patient to come back, maybe they will, maybe they won't. So there's kind of a lot of barriers, on top of the fear. So kind of together, so many women aren't thinking about it. If they are thinking about it, they're saying that's nothing I would ever do. And now a lot of women are talking about it and realizing that they're missing out, on at least a discussion with their provider
Let's unpack
on
what
what are
you
the best.
so let's unpack what you shared. So
Yeah.
when we spoke about this study that they did,
Yeah.
when they did it like many years ago, and then it's about 20 years ago, they kind of like went on the news and said they're not doing this anymore. But what was the study? What were they giving women, and what was it supposed to do? What were they looking for? And so I really want to debunk sort of understand this study and the repercussions of this non stopping the study, and also the way it was reported and the numbers and the statistics and like the way they reported it kind of put this big fear in. And let's kind of like take it back. So let's kind of go all the way back to what were they looking at? Why were they giving these hormones to begin with? Like, what do these hormones do? Because we were talking about like osteoporosis and heart. Let's go all the way back, but not only for symptoms. So let's go back.
So they were looking mainly, I think the primary endpoint was cardiovascular heart health. They also did look at a lot of secondary endpoints, and they gave women one of two things. They either gave them, CEE, which is conjugated equine estrogen, which is just estrogen by itself. And that is for women who do not have a uterus. If they had a hysterectomy, or they don't have an intact uterus, they can get just estrogen. And that's because estrogen causes the endometrial lining, the lining of the uterus, to grow, to proliferate, and that could cause cancer of the uterus. So for women that have a uterus, they need to take a progesterone to thin out that lining. So in the WHI, it was CEE for women without a uterus, and for women with a uterus, it was Prempro. CEE with NPA, NPA, which is a kind of progestogen to protect the uterus. So those were the two arms. And then in 2002, they stopped it because they said there was a increase in breast cancer and rates. And it was actually not a statistically significant increase, but they had, because the study was going to look at, does this have benefit for women irrespective of their symptoms, they had such strict safety measures that even if it was not a statistically significant change, they felt it was too much of a change, and they said, we're done. So in the past 20 years, there's been a lot of analyses of that data to look back, and see, was this really right? All of those things, and kind of look at also the difference between those and just the estrogen and estrogen plus progesterone. And looking back, it actually was that the women in the estrogen only group actually had lower rates of breast cancer than those in the placebo group. And the women in the estrogen and NPA, they did have possibly slightly increased risk of breast cancer. They did not have any increase in death from breast cancer, but there was a slightly increased risk, not statistically significant. So since then, there's been a few studies to look at breast cancer risk. Does it exist? Does it not? What is the magnitude? And we still don't really have anything definitive, but we can safely say that if there is an increased risk, it is very, very slight, and we haven't seen any increased risk in breast cancer deaths. So any breast cancer diagnosis is terrible, and over 90% of breast cancers today are curable. So we kind of have to keep it in perspective of things, of risks that we take in our everyday life. So let's say there is a slightly increased risk of breast cancer. The risk of from hormone therapy is less than drinking an alcoholic beverage every day, which is something that we don't tell people who have one glass of wine a night that you're slightly raising your rates of breast cancer. Maybe we should, but we don't. So it's kind of just to keep in perspective just the amount of fear of breast cancer and actually know what the risks are and what the benefits could be for a specific person. There's also been some studies kind of to look back and see, does it matter what kind of progesterone you use? And so for women, so today, often, not always, we use a progesterone, which is the same molecule that our natural progesterone in our body.
Is that what
So
bioidentical is?
yeah, so usually we do bioidentical progesterone because we think there's some decreased risks, but not always. There are still other safe and effective forms of progesterone if women can't tolerate the prometrium, which is the kind of the bioidentical one. Then there's other options that are safe and effective. We start.
Interject you with the word bioidentical, and then I
Sure.
really want to get back to our topic, but I
So
mean, it's safer.
bioidentical is a marketing term. And often the people using that term are the ones who are trying to sell you compounded hormones that you have to pay for. And most societies will tell you are generally much less safe than FDA approved options that are monitored. So often we end up using kind of similar to the hormones in our body. But not always. There are other options. And like in the WHI, they did use CEE, conjugated equine estrogen, which is different than often today we use estradiol, which is more bioidentical. But that's kind of a marketing term. And it doesn't necessarily mean safer. Every medication has its risk benefits. And but each progestin would have a tiny bit different side effects. So there was looking to see if maybe, prometrium, which is oral micronized progesterone, is safer than MPA. Is it? Possibly. We do have some data to say that maybe that breast cancer risk doesn't exist or is less with prometrium, which is what we often start with now. So really, when we look back at the WHI, we kind of have to keep it. And sorry, one thing that's really important to look at was they did see increased risks of stroke and other heart disease. But when we're looking at who they enrolled in the trial, most women were much older. The average age was, I think, over 65, and significantly post-menopause. So the theory is that, estrogen is really good for all the vessels in our body. And when we lose estrogen, that is what leads to increased risk of heart disease and other vascular issues. But after a long time without estrogen, your vessels kind of get used to it. Your veins and arteries get used to it. So the thought is then if after 20 years without any estrogen in your body, you give estrogen, it causes a lot more issues than if you start when you're younger. So the accepted, I would say standard, and some people do fall outside of this, is that ideally hormone therapy should be started within 10 years of menopause. And to kind of give the most benefit. And most of our safety and benefit data shows that given within the first 10 years after menopause, usually before age 60 is really ideal. And a lot of the data we do have that looks at benefits of hormone therapy on heart and brain and all of those things, those really the biggest benefit is for early postmenopausal women and not for women who are much, much older to start at that time.
Okay, so the WHI, it seems like it wasn't talking to women of early menopause. Like I also read many of the subjects were really much, much older. That's not us to start with. So we're not really even comparing the same things. While every case is a case, especially for that person. the numbers were so much, the increase was so small that it's comes into the conversation of trade-offs, or quality of life versus potential risk, and all of those things to really talk about. But what we also didn't talk so much about, like, we were talking a lot about the benefits of the heart and the brain and all of and bone. There's also the quality of life, which you touched on a little bit, of the quality of life living with the symptoms.
And it's more
And
than just quality of life. I mean, vasomotor symptoms or hot flashes and night sweats, it's more than quality of life. If someone is having multiple hot flashes throughout a day and they can't function, people who are waking up throughout the night, that has significant health benefits, both cardiovascular and mood and all of those things, and weight gain. Sleep is so important. And we also have some evidence that even for women who are sleeping okay, vasomotor symptoms, the more vasomotor symptoms you have, like higher hot flash and night sweats often correlates with higher risks of heart disease. So there's still a lot more that we don't understand exactly why. And sleep may be a piece of it, but probably not all of it. So there's quality of life, there's anxiety, depression, weight gain. Women who are on hormone therapy have a significantly decreased risk of developing type 2 diabetes. So a lot of these metabolic in menopause, hormone therapy can be very helpful. And I would never want to undermine the quality of life piece, because that is huge. So there's symptoms and there's also disease processes. So it's both, and both are extremely important. And there's still so much we have to learn.
I think that to have to learn piece can put some people off. Like, we don't know, so why should I be one part of the experiment? But I think that there's all those questions and things to reflect about yourself and with your peers or with your relationships. Like, how am I showing up? Am I really irritable? Am I so tired that I am irritable or not able to function? It's like, there's so many pieces that just to say I can't deal with it is not necessarily the best way to deal with it. Like, it's really like slow down and understand your life, like reflect. You can journal, you can kind of look at yourself, and whether it's really like your weight gain and your eating habits and your relationship habits and all of that, it's all part of it.
100%. And I think for any woman, the number one thing to do, probably before speaking to your provider, is to track your symptoms and see what changes are happening, and see kind of when and how bothersome, right? Whether it's brain fog, which is a huge problem for so many women with or without hot flashes, night sweats, weight gain, sexual dysfunction, all of those things you might not even realize are happening. You might not realize are part of the perimenopause or menopause transition, because everyone has these symptoms at different times in their life. Many women start up to 10 years before menopause. The average span of symptoms is 7 to 10 years. That's a long time. If the average age of menopause in the US is 51, 52, then women could have symptoms in their late 30s, early 40s, and really not realize what it is. So kind of tracking your symptoms is so helpful. So you can know what's going on with you, and you can know what is the most bothersome thing. What do you want to deal with? Is it sleep? Is it hot flashes? Is it pain with intercourse? Like, what is
Or what
bothering?
combination of all those?
Or
It's not just
combination?
one.
Yes, 100%. 100%. So, and some women have all of those, some women have none of those, and some women have everything in between.
So let's talk a little bit about like the vaginal dryness and like really like localized hormones.
Yes. So, so now we call it GSM, genitourinary syndrome of menopause. Doctors used to call it vaginal atrophy, which kind of, it was not a great term, but also missed out on a lot of the pieces because it's so much more than just vaginal dryness. So the vaginal tissue and the bladder wall and a lot of the pelvic floor really needs estrogen to really thrive. So a lot of women, whether it's premenopause or postmenopause, could have significant vaginal dryness, which could lead to pain with intercourse. It could lead to urinary tract infections, pelvic floor dysfunction, a whole host of issues. I'm going to put this plug out for vaginal estrogen that almost everyone in the entire world can safely take vaginal estrogen with zero issues. People with clotting disorders, people with family history of anything. The only people that should discuss with their oncologist are women who are actively undergoing breast cancer treatment or a GYN cancer should discuss with their doctor. And even then, we're kind of seeing more and more data about the safety and efficacy. We have some guidelines on women who are post breast cancer treatment and what they can use and when, and it's definitely a discussion with your doctor. But for most people, the vast majority, it is very safe and it is very effective in helping pain and urinary tract infections. So for a postmenopausal woman who's having recurrent UTIs, actually the first line of treatment is, if she's not already on it, give her vaginal estrogen.
Is that over the counter or is that with a prescription?
Great question. So actually in the UK, it's now over the counter. In the US, it is prescription. And there's 3 forms. There is a cream, a tablet that's inserted, and a vaginal ring that sits in there for 3 months and is changed. And a lot of it is kind of insurance dependent. Although now you can get estradiol cream for pretty cheap from a few of the online pharmacies. I think Amazon, but there's a few other of like the subscription ones, and I'm blanking on the name right now, that it has become a lot less cost prohibitive, which is great. So it should be easily accessible for everyone. And there's really almost no contraindications. So your doctor should be fine prescribing it for you because it is really safe and really effective. And it can really be helpful. And that's one thing that some doctors are saying maybe even preventatively to use because it really can prevent a lot of issues long term. And while many menopausal symptoms go away for most women, vaginal dryness gets worse. It doesn't improve with time.
So this is just localized. It doesn't help with the bone health and everything else. It's just
No.
the vaginal for the pelvic floor area, that area.
Yes. The
And it's
vaginal
applied
walls,
in that area,
bladder.
whether it's by cream or by tablet, and it's just for that area alone, and it addresses those issues.
Yes, there's not really any systemic absorption. There are some really nitty gritty studies to look for women, and this is for women with hormone receptor positive breast cancer. They're really looking at maybe they should use a tablet instead of a cream because maybe a cream, the estrogen levels rise a tiny bit and then come back down. But for the general population, it is safe. You do not need progesterone with it because it does not affect the uterus. So it also doesn't help with any of the other symptoms, but there's also not any of the other risks. So it's really safe and effective and very locally acting. Creams are maybe work a little bit better than the tablet, especially for women that are having pain around the entrance to the vagina. We often recommend creams because you can just put a tiny bit on the outside. But if someone doesn't like that, tablets are great. And for someone who is either, older and has mobility issues or has some kind of arthritis and, putting something, administering something themselves could be difficult, then the vaginal ring is really nice because their doctor or provider might even be able to change that for them every 3 months. And it could help with urinary incontinence and UTIs and all of those things.
Yeah, so we spoke about that specific. So those people who don't want to take HRT in general can just go localized. But if you took HRT general, it would address the vaginal dryness?
It's a great question. Around 60% of women on systemic hormone therapy don't need vaginal estrogen, but that still leaves a lot of women who do. And that's because the systemic hormones that we use are really low dose in menopausal hormone therapy. And for a lot of women, it's not enough to really reach and give the vaginal tissue all of the estrogen that it needs because it does need a good amount to function properly. There's a lot of estrogen, there's a lot of hormone receptors there. So many women do fine and many women still need, and it's not contraindicated at all to take them both together.
What I'm also hearing from all of this is that there's a lot of conversations to be had with the provider who really understands and will give you the time. but it also helps to come prepared with your questions and with some of your your histories, your symptoms, your tracking your symptoms. I think is like important so that you can really be informed and have a full conversation, and not because if you were finally getting the time, you should do it all, try to get it all in one conversation and then start a relationship with the doctor, because like I'm hearing is like you might have to change it or you might have to adjust. So like it's really important to get started and not to keep away because it's you don't know somebody or because it's too big of a topic. Because I know that there are many people who just will kind of tumble along life dealing with it because it's something that you can deal with. You know, it's not like a broken foot that you can't walk, even though it's so difficult in other aspects of your life. And so people just bumble along and say that, you know, and then they could have dealt with it differently. And so I think that's really important to become that. And that's why I'm doing this, is to have these conversations so that you know what to be thinking about, what to be looking for. And so thank you. But what kind of doctors are we looking for? What kind of certifications or what are we looking to have, who we have in the conversation? And then next I want to talk about what kind of information to kind of gather in order to have the conversation.
That's a great question. And it really depends on your relationship with your doctor and who they are and what their background is. I think most women think that their GYN will handle their menopause care. And some often they will, and more GYNs are getting certified in menopause care. But it's not something that necessarily a GYN necessarily has time for, or is something that they do very frequently. I think this is hopefully changing now that women are talking about this more, but I read somewhere a study that the average GYN residency had around 2 hours of instruction on menopause in the 4 years. And that's not sufficient. That's probably 2 hours more than all other residency programs, but it's not sufficient. So your primary care doctor, whether they're internal medicine or family medicine, this is something they may or may not deal with. There are, so the Menopause Society has, if you go to their website, you can look up who near you is a menopause certified practitioner. And that could be a good place to start. But if you have a good relationship with your primary or GYN, you could ask them and say, is this something that you do? Or do you have someone that you could refer me to? Because this is something that I want to talk about, and I'm having difficulties, and hopefully they can lead you in the right direction.
Okay, so we're looking for, start with whatever doctor you have and try to get a recommendation, or look at the Menopause Society's website, which we can put the link on later, which is actually where I found you. You're listed there, but there's not a lot of people listed there.
I actually, in September, was at the Menopause Society conference, and I think the list of people who were taking the test this year had gone up a lot. And I mean, there was, I think, 1,800 people in person there, which was amazing. And some of them were GYNs, internists, there was everyone was there, which was amazing to see that people want to learn. They want to take better care of their patients because there is such a need. And almost half of the world population is going to go through menopause at some point. So it means so many women are having symptoms, and this is something that people need to talk about. And now that women are talking about it, they're bringing it up to their doctors, and their doctors are saying, oh, I don't know, let me find out. So there are more resources now than there were 10 years ago. Like I said, I had no idea that this was a specialty 5 years ago, or that this was something that there's anything to do. I have a friend who is a wonderful doctor, and I bumped into him not long ago, and I asked him what he was up to. And he said to me, and he's a well-educated, wonderful doctor. He said to me, oh, what do you do? And I said, well, I do menopause care. And in all seriousness, he said, so what do? You give out ice packs? And he wasn't joking. He was serious, and he didn't mean bad. He just had no idea. And so I said, you'll keep me in business, because women are not going to be okay with that answer anymore. Now that there are books and social media, and the big New York Times magazine article last year that came out, which was great. So now that people are talking about it, people are looking, and hopefully doctors are gonna going to learn more about this because there's so much to learn and so much that needs to be talked about.
Okay, so let's talk about, well, what if you find the doctor, or if you're going to start the conversation, what information to have on hand to have the best kind of conversation?
That's a great question. And so I think journaling your symptoms, and again, depending on your provider, I don't know how much time you're going to have with them. So I think also journaling for yourself, so you know what is the most bothersome for you, is great. I think knowing your personal and family history is important, specifically when it comes to personal history. If you have a clotting disorder, active liver disease, those are things that your doctor would want to know. Right, and personal history of breast cancer. So those kinds of things would be important to bring up, but mainly your symptoms and kind of how they're affecting you. And also to kind of be able to advocate to yourself and say, this is happening. I want to discuss treatment. And that doesn't have to be hormones. It can be hormones. I will say that if your doctor says to you, I don't believe in hormones, then you probably should find a new provider, if they're not willing to have a discussion at all with you. If they say you are not a candidate for XYZ and they give you a real reason, that's one thing. But if someone says, I don't believe in hormones, that is against all of our guidelines and what we know. So that's probably not someone you're going to be able to have a good conversation with. But I would say most doctors are not going to say that to you. They're going to say, okay, what do you want to discuss? What are your symptoms? And then hopefully they'll be able to discuss with you both pros and cons of non-hormonal and hormonal options. And some doctors might lean toward non-hormonal options. But if you come prepared and say, I don't have any personal contraindications, reasons why I can't do it, I would like to discuss hormone therapy. Hopefully they would be either receptive to that or say, that's not something I'm comfortable doing. Let me refer you to XYZ who can help you.
Is family history important? Like, let's say breast cancer or any cancers, and your mother's menopause story relevant?
So your mother's menopause story is very relevant for you as far as when likely you'll reach menopause. Often it could be similar, not necessarily, but it could give you a ballpark. So, and the amount of symptoms your mom had may or may not be similar to what you have. Also, your mom may or may not want to talk to you about her symptoms. So, but if your mom says, she had menopause at age 42, she had early menopause, you might start thinking at a younger age, if you're in your 30s and feeling not yourself, you might want to say to your provider, I'm not feeling great. My mom had menopause really early. Could this be related? Especially because people who do have early menopause should take hormone therapy unless there's a reason why they can't, to prevent heart and bone and brain issues. So knowing your mom's history is definitely important. As far as risk goes, family history is not as much of a player as we think. If someone has a genetic predisposition to have high risk of breast cancer, such as a BRCA mutation, that's definitely something they want to talk to their provider, because we actually have this good evidence to say that hormone therapy does not raise your risk of breast cancer above your baseline elevated risk. So for a woman who has BRCA 1 or 2 mutation and is recommended that she has her ovaries removed, once she has her ovaries removed, if it's before the age of natural menopause, she should be on hormone therapy to prevent issues, even if she has not had mastectomies.
All right. And how about like family history of heart disease or osteoporosis, or whether it's your mother or your grandmother? And does it matter if it's your mother's sisters or your?
So osteoporosis family history, I think, is important because hormone therapy could help prevent osteoporosis for people who are at high risk. So if someone's mother and aunt and sisters all had osteoporosis, that might be a reason to start hormone therapy, even if their hot flashes and night sweats are not terrible. So that could be very important. As far as heart disease, if someone has, really strong family history of early heart disease and their parents, their uncle, their siblings, then that's definitely something they want to talk to their provider about, preferably younger rather than older, to have a nuanced discussion. For women who are at higher risk of heart disease, then sometimes using a transdermal estrogen, which means a patch or a cream, would be recommended instead of taking an oral medication, but it's definitely a discussion to have.
So I'm gathering is that we should come in with as much information, get the family history. It may or may not be relevant to the conversation, but have it with you.
Exactly.
And in
Exactly.
general, just knowing your family history, where you're predisposed to whatever it is, besides that just being interesting information to know, it could actually be helpful. So come
100%.
in with all of that and just like have that conversation with your parents or whoever it
Hmm.
is to get that information. And like I said, it may or may not be relevant.
Hmm.
But let's go back to bone health. So there are things that you can do for bone health itself without HRT.
Oh, yes, definitely. Until age 30, we're building bones. And after age 30, we're either losing or staying stable. And women in general have the steepest rate of loss in the first 10 years after menopause. Um, so important things is making sure you're getting adequate calcium and vitamin D. A lot of women might get enough calcium from their diet. Most women do not get enough vitamin D from their diet. And we're seeing more and more the importance of strength training. So weight bearing exercise is really good for the bones. There's a debate whether even just walking counts, but really kind of putting as much stress on the bones as you can. So running, jumping, and any kind of strength training. And we're seeing more and more the importance of strength training, especially women in midlife and older, because women lose a lot of muscle mass also during menopause transition. So strength training is extremely important for the bones as well as the rest of your body. So those are kind of like preventative things that people can do. And family history plays so much role in this. Because so much of it is genetics and nothing that you can do. For people at really high risk of bone disease, sometimes endocrinologists might use um, like treatments for osteoporosis at lower doses. And that's something you can talk to your doctor about if you do have a very strong family history. But one of the FDA approved indications for hormone therapy is for women at high risk for osteoporosis to prevent bone loss and fracture.
Okay, so let's just talk. You talked about HRT being given as transdermal. Let's talk about a little bit about how the regimen of HRT and just in general, what it might look like,
Sure.
what it is.
Before we do that, I just want to put a plug out there for getting your bone density checked.
Yes.
In kind of the guidelines say age 65, but a lot of people feel that's too late. So it's 65, or if you have any high risk, whether that's family history or personal risk of being on medications that can cause bone loss, or histories of eating disorders or other things that could cause bone loss, it should be earlier. And like I said, most of that bone loss happened in the first 10 years after menopause. So for a lot of people, I think 65 is too late. So I think it's an important thing to know. And I hope at some point those guidelines will change, and many insurances will cover it now for postmenopausal women with or without family history.
And it's a very easy test. It's not like a colonoscopy, which is very
Yeah.
invasive. It's easier than a mammogram. I mean, it doesn't even hurt. Like it's just I've done it, even though I'm not 65, so I'm covered. It's a family story, but it's a very easy test.
Yeah.
So
And
it's like, just do it.
I'm with you.
Right. Okay. So
Um,
I'm glad you gave that plug. So let's go back to talking about the different ways that it's about the different regimens of HRT.
Yes. So we have lots of FDA approved hormone therapy. If you find a doctor who wants to give you a pellet of hormones or some compounded stuff, I would stay far away. We have lots of evidence that those kind of are not safe. They're not regulated. And if they try to sell it to you as bioidentical, they're really just trying to sell you something. Unless someone has, really, really sensitive skin and cannot take any regular preparation of estrogen, then maybe there should be compounded. But for the vast majority of people, regular FDA approved hormone therapy is effective, safe, and much more cost effective than getting something compounded. So for many women, the building block is estrogen is kind of the main thing that they need, which could help with hot flashes, night sweats, brain fog sometimes, sometimes with that weight gain, with a lot of the symptoms. Estrogen kind of is that building block. So estrogen comes in three forms. There is, or kind of four. There's an oral pill, which some people find easier. There is transdermal, so through the skin, which would either be a patch or a cream applied to the thigh, like a gel applied to the thigh. And there is also a vaginal ring. This is different than the local vaginal ring for localized estrogen. There is a systemic version called ring, and that gives off enough estrogen to act throughout the body. And again, a lot of it is insurance and a lot of it is preference. So some women just say, I want to take a pill and it's just easier. And that's totally fine. There is some data that maybe transdermal is a little bit safer for women at high risk for clots and things like that. And so then either a gel or a patch might be the best for them. But if, for whatever reason, their skin, the patch doesn't stay on, they're not absorbing the cream well, then for most women, oral estrogen is a safe alternative, and could work better for some people. So it's really depend on the person. And then, and the vaginal ring, some people just want to set it and forget about it and not have to do something every day or every week or whatever. So that's the estrogen. If someone
with the patch, there's the weekly and there's the semi-weekly, like twice a week.
Yeah,
Is
there's
there a difference, or is that just insurance?
Just depends on the formulation and the dose. But they're both equally effective. So it just really depends on the particular person. And then for progesterone, there is really a couple ways. There's only one transdermal option for progesterone, and it is called Combi Patch, and it's a combination patch of estrogen and progesterone. So for women who don't want to take any pills, that could be nice. The only downside is that you can't adjust anything because it comes in 2 doses and that's it. So if someone needs a little bit higher estrogen, a little bit higher progesterone, you can't switch, you can't make changes. It is what it is. There is a few oral medications that have estrogen and progesterone. And then there is, like we talked about before, oral micronized progesterone or prometrium. And that is actually really good for sleep and anxiety. So for women whose main concern is that they're getting more anxiety and having difficulty sleeping in midlife, you might actually start with just progesterone, even if they are not on estrogen or don't have a uterus. And so there's oral progesterone.
Let's go back a second. You can take progesterone without the estrogen. Like you can just take it for anxiety and I guess at night.
Sleep is really
don't take it in the morning, because if
what?
it's
Oh
good
yes,
for
yeah.
sleep,
No,
don't take it in the morning.
prometrium, should be taken at night. A lot of people it makes them sleepy, and some women take it just for sleep. So, so those are the main options. Sometimes if the oral doesn't work for them, inserting the progesterone transvaginally maybe could be an option. And the last option is a hormone secreting IUD. So a Mirena or something like that could protect the uterus. And so for someone who doesn't want to take a pill every day, or has side effects from the progesterone pill, they could have their doctor insert a Mirena IUD and they don't have to worry about it for 5 years. And their uterus is protected.
Okay, so let's go back. So the doctor can prescribe these estradiol, that's what we're talking
Mhm.
about, or whether it's a transdermal or a pill,
So
or
they can
estradiol
prescribe
only
some kind of
transdermal.
estrogen, yeah, whether transdermal, pill, or transvaginal.
And someone who doesn't have a uterus at all doesn't need the progesterone
Mhm,
unless they need it for these other side effects that you mentioned,
mhm.
but they don't need it for their uterus because they don't have a uterus.
Right.
And we're also talking about someone who had an ablation would need a progesterone.
Yes, yes. Someone with an ablation or any kind of uterine surgery or fibroid removal or anything like that, if their uterus is there, they should be on progesterone.
Okay, so for someone who actually wrote in that her doctor prescribed her estrogen without progesterone, so like for what was that?
So it
Was that
could
because it was
be.
just getting started?
Yes. So if, and that is definitely not unreasonable that if you're just starting to see for a month or two how things go, after 2 to 3 months, like for sure, there should be a progesterone there too. But to start off for a couple weeks, a month, and say, let's see how you're doing, that's great. Because sometimes there are side effects with any medication. So if you start them at different times, it could be helpful to know which is causing the side effect. So you can know I need to change this versus saying I'm not doing this at all.
Does HRT work against or with other medications that someone's taking? Like if someone's taking thyroid medication, is that because that's also hormonal? So is there anything to consider?
So that is that they do not interact. Usually thyroid hormone needs to be taken by itself in the morning. But especially transdermal estrogen doesn't really it bypasses the liver. So oral estrogen is broken down by the liver. So it's something that your doctor should be able to check if there's any interactions and how to deal with that. Very similar to, birth control pills can raise or lower certain medications, but it should not be an issue for your doctor to be able to plug in and figure out.
I guess that would adding to the list of what to talk to your doctor about is what medications you're taking.
Well, your doctor should, before your doctor prescribes you anything, they should know what other medications you're taking as a general
The
rule.
conversation, before the prescription, but even in the conversation, before we
Right.
even get to
Right.
the prescription, they should. So just like we'll add that to the list of
Yes.
what
Yeah.
information to bring in.
Yeah.
So we covered so much about. I mean, there's so much more. People have a lot of fear, and I think that we kind of put some information out there. Like the idea is if you don't want to take HRT, that's totally. And I think you and I both respect that, but it should be coming from a place of education rather than a place of fear or
Mhm.
and not having enough information. So these kinds of conversations are really important. And if anyone has any other questions, they can reach out to me. We'll try to get that information. They can reach out to someone like yourself or talk to their doctor. But I think it's important to really have these conversations so that we are more knowledgeable, so that we are doing what's best for ourselves from a place of power and not from just it's too overwhelming. And it is overwhelming. I'm not saying that it's not, but I think that we can break it down into pieces and start getting information so that we could do the right thing by ourselves. And what I'm also hearing from between the lines is this a lot of experimentation. So just because something didn't work the first time or didn't give you the exact results that you were hoping for, doesn't mean that you should just discard the whole idea of getting help.
100%. And, because every woman's body is so different. Every woman reacts to hormones so different. And for some women, they just need a baby dose of estrogen and they're feeling amazing. For some women, they might need a higher dose, especially depending on their ages and things like that. So or how they reach menopause. So someone with surgical menopause who had their ovaries removed, where it's an abrupt change, they might need higher doses for a while, especially depending on their age, than someone who at age 53, slowly lost her estrogen and is now having some symptoms. She may need a much lower dose. So it really is really dependent. And there is definitely some trial and error to get people feeling their best because there's no blood test that tells us, oh, this is where exactly you should be. It's not like thyroid hormone where we often measure exactly where we want that range to be. Because the whole point is to help people's symptoms and different people absorb medication differently, like with all hormones. So there's definitely some trial and error. But hopefully everyone can find what works for them. And there are also, for whatever reason, hormones don't work for someone, there's plenty of non-hormonal options out there that they can talk to their doctor about if they can't or don't want to have hormone therapy. But women shouldn't be suffering in silence and saying this is normal, it's natural. So many things are natural and we treat people for it. All disease processes are natural. And
There
we
was
don't
a
say,
time
oh,
where we talk about natural childbirth and epidurals were awful. And I mean, some people still choose not to, and we don't have to go into choices, but I think the idea of just not doing it, just like I didn't have an epidural and I get it's a separate conversation. It's like, because epidural in a way is a one-time thing. It's the birth, but this is
mhm,
like an everyday thing. So I think it's a whole different conversation about being brave and not having an epidural versus living every single day with the symptoms.
100%. And also the consequences of those symptoms, as it's not just the hot flashes and night sweats, it's everything that goes with it and how it interacts with people's partners and children and jobs and what they want to do with their life. So it is right a daily thing. And hopefully women will are more and more going to have that opportunity to talk about this, both with their moms, their sisters, their peers, to know what's normal, you should get that from your doctor, but also just to not feel so alone and be able to talk about these things and then be able to talk about it with their doctor to hopefully get the treatment that people need.
I'm so glad that you're part of that conversation. So good luck on your new move to New York.
Thank you.
There's a lot of women here who need your work. Where can people reach you or find your work?
Okay, so hopefully I will be up and running with a practice in the next 6 months or so. If anyone is interested in reaching out and having us reach out to you when I'm up and running, you can email me at avigayilrappmd@gmail.com. That's AVIGAYILRAPPMD@gmail.com.
Right. So thank you so much. There's tons of questions still, but let's wrap it up here and maybe we can have another conversation with some more
Okay,
questions.
great. Thank you so
All
much.
right. Thank you.
Take care.
Thank you for joining me in another fascinating conversation about midlife. If you'd like to reach me, Devora Krasnianski, to talk about your midlife or anything else, you can reach me at jewishmidlife@gmail.com. You can also find us on our website, jewishmidlife.com, and follow us on Jewish Midlife on Instagram or Facebook, and join our conversations in our Facebook group at facebook.com/groups/Jewish Women Talk About Midlife. And share what we're doing with your friends and others in the midlife phase.